Well, good day, everyone. This is Chris back again with the Ancient Scholar, and I'll continue on the introductory to cardiovascular pharmacology and blood clotting pharmacology for respiratory therapy students. Of course, this video will be open to the general public, and anybody can see them. And let's go ahead and continue on. This will be video 4 in a series of videos, and now what I want to do is I want to start talking about some of the anticoagulants, antiplatelet medications, and the fibrinolytics, and we'll cover all those, or some of the major ones and major implications and concerns and considerations in this video. So let's go ahead and talk about anticoagulants first here. Some of the major anticoagulants that we run into in the clinical environment. Anti meaning against, and coagulant meaning blood clotting, so anti-clotting agents. And the big 4 agents that we commonly run into are heparin, warfarin or Coumadin, low molecular weight heparin or Lovenox, and Plavix. So let's go ahead and talk about heparin real quick here. Heparin is typically an intravenous anticoagulant medication. It prevents clotting. Okay, it does not break clots down. Okay. It does not break clots down. It prevents new clot formation from occurring. When we administer heparin, one thing that we need to monitor is the PTT, the partial thromboplastin time. If you remember from the last video, we talked about the PTT is a measure of the intrinsic pathway that leads to the common pathway in the clotting cascade, and that's actually where heparin works. Heparin is its primary use that we run into is for acute coronary syndromes. Acute coronary syndromes are generally the result of an acute process that happens in one of the coronary arteries of the heart, one or more of the coronary arteries in the heart. And generally it's the result of a clot being formed. Generally what you have is you have a deposit in one of the arteries. That plaque or deposit becomes unstable, it breaks off, it exposes collagen, the blood vessel, and that activates a clotting cascade, and a clot develops, and then we develop what's known as an acute coronary syndrome. There are 3 major types of acute coronary syndromes. There's a type known as unstable angina, which is simply angina or ischemia to the heart, but unlike stable angina, where people can generally manage this and rest and take some medications and do okay, unstable angina doesn't go away. The pain that they have in their chest doesn't go away, but there's no damage to the heart. The next type of acute coronary syndrome is something known as a non-STEMI or an NSTEMI, and this is a non-ST elevation myocardial infarction. It used to be called the non-Q-wave MI. The newer terminology is an NSTEMI. And you guys have not talked about ECG interpretation yet, so this won't make a whole lot of sense. But basically there are 2 types of what I'd consider a quote-unquote bona fide heart attack, where you actually have injury and some type of cell death occurring. You have this, what's known as the non-STEMI, the non-ST elevation MI, so the ST segment. If you remember from the beginning of this video, the T wave, the QRS went back to the baseline, and then it was followed by the T wave. Well, in the NSTEMI, you do have that, in fact, that the T wave does come after the QRS complex, but the T wave can look a little funny. Often the T wave is inverted. And we'll talk about that in a lot more detail here in about 1.5 years, so don't worry too much there, guys. And this is, sometimes they call this a silent heart attack, which I don't think is a great definition, because I've seen a large number of patients come in that have actually the classic signs and symptoms of a heart attack or a myocardial infarction, but they don't have elevation of their ST segments. And then, of course, the last type of acute coronary syndrome is something called the ST elevation MI, or the STEMI. This used to be called the Q-wave MI. ST elevation, basically it happens as the T wave kind of blends into the QRS complex, and you don't have that return to the baseline. This is generally of great concern, this type of heart attack or acute coronary syndrome, and is generally treated very aggressively. Okay, some other uses for heparin, often people that have central catheters or central lines in place will receive periodic injections of heparin to keep these catheters from clotting up. Heparin is sometimes used in hospitalized patients to prevent the formation of a deep venous thrombosis, or a DVT, and to help prevent that DVT from developing and breaking off and becoming pulmonary embolism. One concern that we need to consider with heparin is something known as HIT, or heparin-induced thrombocytopenia. There have been there's evidence that upwards to even as high as 10% of patients who receive heparin will or could potentially develop heparin-induced thrombocytopenia. HIT can potentially be problematic and even very serious and fatal, because a thrombocyte is a clotting cell, basically, is what it literally means, a thrombocyte. And that, of course, the lay person name for a thrombocyte is a platelet. If you lose a lot of your platelets, because that's what thrombocytopenia is it is generally a rapid, sudden, marked decrease in your platelet count, your ability to clot is going to be highly impaired. And yes, we are given heparin to prevent clotting, but if I develop thrombocytopenia, that pushes me kind of over a line where my ability to prevent life-threatening bleeding is impaired, and I can have life-threatening, or I can have bleeding into my joints or bleeding into my brain, and so on and so forth. So heparin-induced thrombocytopenia is a problem, and we need to be very concerned about that if we give patients heparin. Heparin overdose occasionally occurs. The medication that we can use is a medication called protamine sulfate to reverse a heparin overdose. I don't see it used a whole heck of a lot. If you work in the cardiac cath lab and do interventions, you know they give heparin to patients like there's no tomorrow. It's very impressive the doses of heparin, the amount of heparin that some of these patients will get in the cath lab while they're having their cardiac intervention performed. But occasionally, and that's why we watch the PTT. Their PTT becomes very, very altered, and they are unable to prevent life-threatening bleeding, and you may need to reverse that. You need to be very careful about administering protamine sulfate. There are lots of issues associated with it, including anaphylactoid-type reactions. The next medication is called warfarin, or Coumadin is the other name for warfarin. Coumadin is actually an oral anticoagulant. Heparin is IV, pretty much IV only. Sometimes you can give it subcutaneously, but this is not a medication that you take at home. Warfarin is a very common oral anticoagulant. It inhibits vitamin K. We know vitamin K is essential in the clotting cascade. We monitor the prothrombin time, and we need to monitor that very closely and fairly frequently. And actually, patients that take warfarin or Coumadin have to go to the hospital quite frequently to have their blood drawn and their PT checked. And sometimes they'll have special areas where these patients can go, and they can kind of fast track them and get their labs done, and they don't have to go through all the regular hospital process that occurs. And these are known as Coumadin clinics. One of the primary uses for warfarin or Coumadin are in patients that have atrial fibrillation. Their atria are fibrillating, and you can have some stasis of blood in the atria of the heart, and that blood can kind of coagulate and create clots, and then those clots can potentially break free, and then they get pumped out the ventricle into the lungs and into the brain and cause pulmonary emboli and strokes. So Coumadin is a very common medication for patients that have atrial fibrillation, and as you will learn in your classes on respiratory-related diseases, certain types of respiratory disease can cause something known as cor pulmonale, and you can actually have heart failure, and atrial fibrillation is associated with that. So atrial fibrillation is not an uncommon rhythm in patients that have lung disease. So often we will see patients that have advanced lung disease in atrial fibrillation, and they receive Coumadin or warfarin. Also, you may see patients that have had a heart valve replaced. They'll go on Coumadin or warfarin to prevent clots from occurring from the valve. You basically have a foreign material in the body. If somebody inadvertently overdoses on warfarin, and we think it might be a life-threatening overdose, so there's a drug interaction that leads to the warfarin being more effective than it normally would be, some sort of synergistic or potentiation reaction occurs. There are lots of different drug interactions with these anticoagulants that we need to be careful about. If you need to reverse the overdose, you can give vitamin K, obviously. Vitamin K is associated with some side effects. And really, if you need to reverse these patients very quickly, one of the other things that you can consider doing is something called FFP, or fresh frozen plasma, and that literally is plasma. You take, somebody donates blood, and maybe you've donated plasma before. All of the clotting factors of your blood are actually located in your plasma, so you're giving somebody all of the clotting factors when you give them FFP. So that's warfarin or Coumadin. Another medication is very commonly used is something called low molecular weight heparin. So it is a type of heparin, but is a low molecular weight heparin. The brand name, of course, is Lovenox, and Noxaprin is the generic name. And I actually have a little picture of Lovenox here. Generally, Lovenox is given for DVT prophylaxis, deep vein thrombosis. Prevents clotting, prevents DVTs, and hopefully will prevent pulmonary emboli and strokes from occurring. Generally, patients that are immobile for long periods of time, if they've had some sort of surgery or they're very sick in the ICU, they will receive daily injections of Lovenox, and generally they will get 1 milligram per kilogram of weight. As a subcutaneous injection, it's injected generally into the abdomen, subcutaneous tissue. And one of the things that you might see people when they inject Lovenox, or when they inject medications, they'll rub the area vigorously after the injection, I suppose to help it absorb better or whatever. I have my doubts as to the efficacy of doing that. But Lovenox is definitely one of the medications you absolutely do not do that. You inject it subcutaneously, and you leave the site alone, otherwise they get really big bruises. The next medication, very common, is a medication called Plavix. It is another type of anticoagulant, antiplatelet medication. And Plavix is commonly given in patients that have had stents placed. They've had stents placed in their heart, and to prevent occlusion of those stents, these patients are commonly go home on Plavix, and sometimes this is an oral medication. So Coumadin and Plavix are the only oral medications on this list. Lovenox is subcutaneous, and heparin is an IV and occasionally subcutaneous medication. Okay, just some other anticoagulants or antiplatelets that I want to talk about. Obviously, good old aspirin, ASA, or acetyl salicylic acid. Aspirin inhibits the prostaglandin production, and we've talked about that in prior lectures. We've talked about the early and late phase inflammatory response, and we've talked about the cooxygenase and the lipooxygenase pathways. And this actually affects specifically the cooxygenase 1 pathway, inhibits that, and of course that can inhibit clotting. One thing we need to be careful about with aspirin is people that have very severe asthma and some intolerances to aspirin. There is a slight association with giving aspirin and development of asthma attacks, so it's something you want to be potentially concerned about. Aspirin, of course, as we know, the COX-1 or your COX pathways. I think aspirin actually works both COX-1 and 2 pathways, but it's the COX-1 pathway that we look at for clotting. Also is involved in protection of the stomach, production of the stomach lining, and so with aspirin you can develop ulcers, bleeding ulcers, peptic ulcer disease, and so on. So there are some some considerations with aspirin there. Generally, you'll look at giving 324 or 325 milligrams of aspirin. You'll have the patient chew the aspirin for the best for the greatest amount of absorption and bioavailability. Aspirin is very commonly given in acute coronary syndrome or suspected acute coronary syndrome, and it's one of the frontline medications that we give to somebody who's having chest pain and we suspect them of having an acute coronary syndrome. We try to give everybody aspirin if there are no contraindications or significant drug interactions existing. Another medication that you'll run into, particularly in the ICU, are what we call the glycoprotein inhibitors. And glycoprotein inhibitors are interesting in that they actually inhibit glycoproteins on the surfaces of platelets. And this actually prevents, in essence, it prevents the platelets from sticking together, or we call platelet aggregation. The glycoprotein inhibitors, for the most part, are given as an IV bolus followed by an infusion. They're used for the treatment of acute coronary syndrome. Glycoprotein inhibitors do not break clots down, but they prevent new clots from forming, and it is not uncommon to see patients receiving a glycoprotein inhibitor in addition to, say, something like heparin. So they'll have a heparin infusion as well as a glycoprotein inhibitor infusion. The glycoprotein inhibiting agents seem to be very commonly used for the non-STEMI or the non-ST elevation MIs, and occasionally for the STEMIs as well. It's generally an IV infusion. The two major examples in the United States of glycoprotein inhibitors are Aggrastat and Integralin. In the areas where you will be working, Integralin is the preferred glycoprotein inhibitor. That's just what the physicians prefer. It actually comes refrigerated, and you administer a bolus and follow that up with an infusion. You need to be careful about renal issues. These glycoprotein inhibitors, you need to have decent renal function for optimal elimination. So you may need to be careful if you have, well, obviously with any medication, if they have either hepatic or renal issues because of metabolism issues and elimination issues. But you need to be particularly careful when using IV glycoprotein inhibitors. And the other class of medications that I wanted to just briefly talk about are the fibrinolytic medications. You will sometimes hear the term thrombolytic medications. I really don't like to use this term. It's somewhat of an incorrect term because thrombolytic is basically the assumption that you are breaking a thrombin-type clot down. If you remember, you have thrombin, and then you have fibrin in a fibrin clot. Fibrinolytics literally break down the fibrin clot, okay, which occurs after the thrombin. Okay, so it's more the best way to describe how these medications work is really by calling them fibrinolytics, but people commonly call them thrombolytics. And under practical situations and circumstances, you should take these to be synonymous terms. So let's talk about these. These are actually clot-busting medications. Okay, these literally break clots down. They are commonly administered for two conditions, and that is for an acute coronary syndrome, typically a ST elevation MI, where I have a concluded coronary artery and I can't get the patient to the cath lab. There's a delay for whatever reason. Maybe I'm at a hospital that's far away and I'm trying to get the patient to a cath lab, but there's going to be delay in time. Something like that, or the cath lab team is going to be delayed getting in, or there are two patients having MIs that are already in the cath lab and it's going to be a significant amount of time to get my patient into the cath lab. We may consider these fibrinolytics. The other potential indication is for stroke, and there are two types of stroke. Basically, there are two basic types of stroke. There is what's called the hemorrhagic stroke and the ischemic stroke. Obviously, if I have a hemorrhagic stroke, like I have bleeding inside of the brain, a fibrinolytic agent is contraindicated. But if I have an ischemic stroke within a very narrow time period, right around 4 hours, I may consider giving those patients fibrinolytics. And don't worry, we're going to talk about managing acute coronary syndromes and managing strokes in more detail when we take advanced cardiac life support here later on in the program. And we'll talk about all the indications and contraindications and all the questions that we need to ask because it's very important. Today I just want to focus primarily on the basic pharmacology indications for these medications. So the very first, or the prototype of these medications, is something known as streptokinase. And if you guys remember back to microbiology, I hope that you did camp testing with streptococcus. It's a gram-positive bacteria, and you would culture that bacteria on blood agar. And you would do what's called a hemolysis test. And you would look for primarily you look for alpha and beta hemolysis. The strep bacteria release chemicals that break down the blood cells, and you actually have hemolysis occurring, and you have different types of hemolysis occurring. Well, and this is really right back in the back in the 80s, 90s is when this really kind of came out and began to proliferate. Somebody said, hey, maybe I can put that, what the strep bacteria do to some good use, and lo and behold, we were able to isolate the substances that cause the blood to hemolyze, and through probably through recombinant DNA technology, we were able to purify the substance, and it's called streptokinase because it's literally kinase is an enzyme, obviously. And it comes from strep, and it breaks down clots. And this is really the first generation medication. It was reasonably effective. There were some issues with with all of these medications. If I give them, there's always a risk that I could have internal bleeding or hemorrhaging occurring, particularly within the brain. And that's obviously one of the things that we're really concerned about. And then some of the second generation, newer generation agents came out, Redivase or Rediplase, Activase or TPA is the other name, and then TNKase or Tenecteplase. All of these have roughly the same efficacy. They all tend to work. Redivase tends to be very popular down here in New Mexico, and I actually have a picture of Redivase. You actually have to reconstitute it. It comes in a 10-unit vial. I believe it's sterile water that you mix, and it's 10 units, and you'll administer 10 units slow IV push, and then in 30 minutes you'll administer a second 10-unit dose. Another medication is called Activase or TPA, and this is the one that you can use for ischemic strokes if you've ruled out hemorrhage through a CT scan of the brain. And this has a bit more of a complicated infusion. You give a little IV push bolus dose followed up by a maintenance infusion. And then this is the one that I personally like quite a bit, simply because it's a one-time thing. It is a IV push, one-time dose, and you're done. So it's a bit more convenient, but I believe that it has a slightly higher risk of brain hemorrhage than some of the other agents. So again, these are used to bust clots, primarily used to treat myocardial infarction and ischemic strokes. Occasionally, you'll see fibrinolytics used to treat pulmonary emboli. And other types of clots, like if somebody has a big central line in, and maybe they're a cancer patient or they have a really bad infection, and you need that central line to be patent, and it gets clogged up with a clot, they may inject a little bit of a fibrinolytic in there to kind of dissolve that clot. So those are just some other indications for these medications. Okay guys, so we've covered quite a bit of material here in this lecture. I'm going to go ahead and cut it off here, and hopefully we'll only have one, maybe two more lectures to go, and we'll have finally gotten through all the pertinent cardiac stuff that you need to know as a respiratory therapist. Okay guys, as always, thanks for hanging in there.